This lecture will be on facial bones. When we talk about facial bones, we're talking about the maxilla, which is the upper jaw or the maxillary bones. Talking about the zygoma or zygomatic bones, lacrimal bones, nasal bones, inferior nasal concha, palatine bones, vomer, and the mandible or lower jaw. Looking at the maxillary bones, we have a right and left. This is the largest immovable bone of the face, and the two are united at the midline below the nasal septum, and each maxilla assists in the formation of the mouth, the nasal cavity, and one orbit. From a lateral perspective, we see that it has a body and four processes. We have the frontal process, the zygomatic process, the alveolar process, and then here we have the anterior nasal spine. From the frontal view, we see the frontal process, the zygomatic process, and the alveolar process, and the body of each maxillary bone consists of a maxillary sinus. We have the hard palate. This is the inferior surface with one process. This is the palatine process of the maxillary bone. There are two palatine processes that form the anterior portion of the roof of the mouth, and this is called the hard palate or the bony palate. Articulations of the maxilla are with two cranial bones, the frontal and the ethmoid, and with 7 facial bones, the zygomatic, the lacrimal, nasal, palatine, inferior nasal concha, the vomer, and then the opposite maxilla. When looking at the zygomatic bone here in gray, we do have one on the right and the left. Each is located laterally to the zygomatic process of each maxilla. Zygomas are also called malar bones. They project posterior to join the zygomatic process of the temporal bone to form the zygomatic arch. And the most prominent portion of the zygomatic bone is the zygomatic prominence. As we look here, we can see again that it articulates with 3 cranial bones and 1 facial bone. Articulations of the zygomatic bone, the 3 cranial bones are the frontal, the sphenoid, and the temporal, and then articulating with the opposite maxilla. Lacrimal bones, we have a right and a left. These lie anteriorly on the medial side of each orbit, just posterior to the frontal process of the maxilla. And lacrimal bones are closely associated with the tear ducts. You can see the lacrimal bone here in kind of the yellowish green color. The nasal bones also have a right and left nasal bone. The two fuse to form the bridge of the nose. They lie just anterior and superior to the frontal process of the maxilla. They lie just inferior to the frontal bone, and the junction of the two nasal bones with the frontal bone forms the positioning landmark that we refer to as the nasion. Articulations here with the nasal and lacrimal bones, with 2 cranial bones, the frontal and the ethmoid, with 2 facial bones, the maxilla, and then the opposite nasal bone with respect to the nasals. Inferior nasal concha, a right and a left. These are 2 thin scroll-shaped facial bones projecting laterally projecting from the lateral walls of the nasal cavity on each side and extending medially. The superior and middle nasal concha are also called turbinates, and these extend from the ethmoid bone into the nasal cavity, and you can see these here on the right inside the nasal area. Palatine bones, the right and left, vertically extends upwards between one maxilla and one pterygoid plate of the sphenoid bone, and horizontally makes up a part of the hard palate. Here you can see that vertical portion and the horizontal portion being displayed here on the left. Bony nasal septum is formed by the perpendicular plate of the ethmoid bone and the vomer bone. Anteriorly, it is cartilaginous and called the septal cartilage. Deviated nasal septums is when the septal cartilage has been moved from the midline. The vomer is a single triangular shaped bone that forms the infero-posterior part of the nasal septum. And you can see the vomer bone here, as well as the septal cartilage and the perpendicular plate of the ethmoid bone. Nasal septum, the articulation are with 2 cranial bones, the sphenoid and the ethmoid, and with 4 facial bones, 2 palatine bones and 2 maxilla. The vomer articulates with the septal cartilage. Here we're looking at the mandible. Now this is a lateral perspective. Now the mandible is the largest of all the facial bones and is the only movable bone in the adult skull. The angle or gonion of the mandible divides each half into 2 main parts, where we would have the ramus and the body. Now the ramus is anterior to the angle while the body is superior to the angle, and the alveolar processes are the ridge that extend along the superior portion of the body. From a frontal perspective, the union of the bodies of the mandible is called the symphysis or symphysis menti, and the flat triangular surface is called the mentum, the mental protuberance, or the mental point, and we'll refer to that portion often. Located on each half of the body are the mental foramina that serve as the passageway for nerves and blood vessels. Here we have the ramus. The upper portion of each ramus ends in a U-shaped notch termed the mandibular notch. At the end of the notch is a process called the coronoid process. The posterior process of the upper ramus is called the condylar process or condyloid process or mandibular condyle. And the condyle here you can see has a head and a neck. And the head of the condyle articulates with the temporomandibular fossa of the temporal bone to form the TMJ. When looking at each orbit, these are cone-shaped. The outer portion of the rim is called the base, where the posterior portion is called the apex. The apex corresponds to the optic foramen, and you can see that there is about a 37-degree medial angle between the base and apex of the orbit. Base of the orbit consists of 3 bones, the frontal, the zygoma, and the maxilla. Each of the orbits is composed of 7 bones. The base of each orbit is the frontal bone or orbital plate, the maxilla and zygoma. The medial wall is the lacrimal bone. The posterior orbit is formed by the sphenoid and ethmoid bones, and the innermost posterior part is formed by the palatine bone. Each orbit contains 3 small openings in the posterior portion. The optic foramen in the sphenoid bone is located posterior at the apex. The superior orbital fissure is an opening between the greater and lesser wings of the sphenoid bone and is lateral to the optic foramen. And the sphenoid strut separates the superior orbital fissure and the optic canal. And here you can see the optic foramen, the sphenoid strut, the superior orbital fissure, and then inferiorly and lateral, the inferior orbital fissure. So let's talk about the positioning routines. So for facial bones, we're going to start with the lateral. We do not need to include the entire skull in this, so we can adjust our collimation to be 8 by 10 lengthwise with a 40-inch SID. We will place the affected side closest to the image receptor. We will make sure that we have the patient's head in a true lateral. Recall that means MSP is parallel, IPL perpendicular, and the IOML perpendicular as well to the central ray. And the central ray is perpendicular to the zygoma, midway between the outer canthus and the EAM. We'll suspend respirations, and on our evaluation criteria, we expect to see superimposed zygomatic bones in the center with the EAMs and orbital roofs in the collimated field. So here we see a true lateral position. This can be done with the patient erect or recumbent, but again, central ray is going to be perpendicular centered to the zygoma, which will be midway between the outer canthus and EAM. And again, maintaining a true lateral position. As we look at this, the zygoma should be in the center of the radiograph. We want no rotation, evidence again by that anterior-posterior displacement, no tilt, evidence by a superior-inferior displacement, and of course optimal exposure factors to include all of the facial bones, including, as seen here, the mandible. The PARIETOACANTHIAL projection, this is the Waters method. Again, we're using a 10 by 12 collimation, lengthwise 40-inch SID. For this positioning, we want the mentomeatal line perpendicular to the image receptor, adjusted so the orbitomeatal line will form a 37-degree angle to the image receptor. Mid-sagittal plane should be perpendicular, and the central ray is going to be perpendicular and exiting at the acanthion. Respirations are suspended, and we expect to see the petrous ridge inferior to the maxillary sinus, as well as no rotation or tilt. This is being demonstrated on the table. Most often these are done erect, but you can see here that the mentomeatal line is perpendicular to the image receptor. Central ray is perpendicular and exiting at the patient's acanthion. Here we see it erect, again with mentomeatal line perpendicular. Central ray is perpendicular, and there will be a 37-degree angle here between the orbitomeatal line and the image receptor, and again that should place the petrous ridge below the maxillary sinus. As we see here, the up arrows indicating the top of the petrous ridge, clearly identified as being inferior here to the maxillary sinus, and of course you can see the orbital ridge. On a PA axial Caldwell method, again an 8 by 10 collimation, lengthwise 40-inch SID. Orbitomeatal line will be perpendicular. We want no rotation or tilt. We do use a central ray on a Caldwell method. It's a 15-degree caudad central ray centered to exit at the nasion, and as far as our evaluation criteria, with the 15-degree caudad Caldwell, we do expect to see the petrous ridges in the lower 1/3 of the orbits. So we see here both erect and on the table with the Caldwell, we have our orbitomeatal line perpendicular to the image receptor with a 15-degree caudad angle seen here to exit at the nasion. The petrous ridges should be projected in the lower 1/3 of the orbit with no rotation and optimal exposure factors. So we will be looking lateral here to the orbit and the lateral aspect of the skull to ensure that we have equal distance and showing no rotation. On lateral nasal bones, we'll be looking at only the lateral. Again, collimation, start with an 8 by 10, but we will be adjusting that collimation down. Can be done lengthwise or crosswise with a 40-inch SID. We do want to maintain that true lateral position. We will be doing projections of each individual side. The mid-sagittal plane will be parallel to the image receptor, the interpupillary line perpendicular to the image receptor. The infraorbitomeatal line will be perpendicular to the front edge of the image receptor, and the central ray will be perpendicular and 1/2 inch inferior to the nasion, and our criteria states that the nasal bone should be in the center of the collimated area so that we see all of the nasal soft tissue, the anterior nasal spine, and the frontonasal suture all must be included. So again, you can do these on the table or erect. We're seeing here that we have our interpupillary line perpendicular as well as the central ray centered to a point there 1/2 inch inferior to the nasion. So it'll be appearing to go right through the orbit as well. So you do have to include the soft tissue, anterior nasal spine, and the frontonasal suture. When we're talking about zygomatic arches, we'll start here with the oblique infero-superior or the tangential. You can see that we'll start with an 8x10 lengthwise collimation at a 40-inch SID, but we will be adjusting that collimation to a smaller amount as we center on the affected side. So the infraorbitomeatal line will be parallel to the image receptor. The head will be resting on the vertex, and we'll be starting with that submento vertex position, and then we'll intentionally be rotating and tilting to get that zygomatic arch in profile. So we'll rotate the head 15 degrees towards the side to be examined, and then we'll tilt the chin 15 degrees towards the side of interest. The central ray will be perpendicular to the IR and the IOML, with being directed to the zygomatic arch of interest, and we should be able to see the zygoma of interest, the arch, free of superimposition of the mandible or the temporal bone. And so we will start from that SMV position, and we will be rotating. I would suggest you rotate first and then tilt, and then we'll be looking for the nice shadow over here. So infraorbitomeatal line parallel to the IR, central ray perpendicular to the IR, and the IOML centered to the area of interest. And we can see here, while we're looking at this, you can see the nice zygomatic arch free of superimposition. If we're doing both together, we'll be doing the SMV position. You can see here roughly 8x10 collimation, 40-inch SID. The infraorbitomeatal line is parallel to the IR. The mid-sagittal plane is perpendicular. We want no rotation or tilt of the head, with a perpendicular central ray centered to enter midway between the zygomatic arches at the level of 1.5 inches inferior to the mandibular symphysis, and we expect to see the mandibular symphysis superimposing with the frontal bone and a symmetrical appearance of the arches laterally. So this is your SMV. You can see here the head has to be extended back, with the infraorbitomeatal line being parallel here to the image receptor and perpendicular to the central ray. And as we look, they kind of sometimes refer to this as like a bucket handle, but we should be able to see each side free of superimposition and demonstrated laterally. Looking at the AP axial or a modified TOWNE, again 8x10 collimation roughly, crosswise 40-inch SID. Using the orbitomeatal line, but if we can't use the orbitomeatal line, we can use the infraorbitomeatal line. We want no tilt or rotation. If using the orbitomeatal line, then the central ray will be 30 degrees caught at. If using the infraorbitomeatal line, we'll be using a 37-degree caught at angle, with the central ray set to enter 1 inch superior to the glabella midway between the arches. And the evaluation criteria states that the zygomatic arches should be seen free of superimposition of the mandible, and we will use definitely less technique than the skull on these to visualize the arches. So here you see this AP axial TOWNE method here with the 30-degree central ray angle to OML, 37 to IOML, centered to pass 1 inch superior to the glabella, going right through the arches here, as you can see by that shadow. And here you see your arches off to the side laterally.